Good afternoon, everyone. Welcome once again to the Independent Sage briefing. Now, every week we receive a large number of really interesting questions, and some have backlogged us. So we're going to dedicate today to a public question and answer session driven all by your questions. But before we get to that, I've just got a couple of announcements for you. First, we're going to move the briefings to a fortnightly schedule. This is not because we think the pandemic is not still with us and a very great concern, but we do have struggle with many of our experts who have huge clinical, academic, public health commitments. And so we're going to move it to 2 weeks. And of course, if things hot up in any way, we can move it back to once a week. The second is an announcement linked to funding. All the experts on IndySage give their time for free, both the public sessions and the meetings we have in the week. Our partner, the Citizens, support us with streaming the briefings, maintaining our website, our Twitter account, liaising with the media and members of the public, and that does cost money. Now, all of you generously gave to the cause and helped us last year by donating to our crowdfunder, and we cannot thank you enough for that. But current funds are running out. And so we're launching a new crowdfunder today, and you can find the links to that on our website, on Twitter, and on the YouTube stream. Now, we know money is very tight for many people, and only give if you feel able. Don't worry if you don't. But if you would like Independent Sage to continue for the coming year, which we feel needs to be done because of the continuing pandemic and the public inquiry, then do see if you can contribute a small amount. This is a unique partnership, actually, and we value it as much as you because it is unique in bringing independent science and health experts to the general public. Anyway, with those announcements done, I'd like to invite, this week we have our High Priest of Probability, our Cardinal of Charts, Dr. Kit Yates, to give us a presentation on the latest numbers. Over to you, Kit.
Thank you so much, Anthony. Cardinal of Chance. I've never been introduced like that before. I'm going to give you an update on the latest COVID data with particular interest in the UK. So here's the summary. Cases seem to be rising. Hospitalizations are also increasing. Deaths that are being recorded are plateauing. That's as a result of the plateau of the last wave. And in terms of vaccination, people are becoming increasingly far out from their most recent dose of the vaccine. So that's what I'm going to cover today: prevalence, hospitalizations, deaths, and vaccination. A sort of fairly standard set of numbers, but there's a little bit of intricacy to deal with. So the ONS infection survey just came out at 12 o'clock, and it shows relatively even prevalence across the UK. Between 1.3 and 1.5%, so somewhere between 1 in 60, 1 in 70, 1 in 80 people infected at the moment. I know what ONS is suggesting is actually their data goes up to the 24th of January. They're suggesting that in the week up to the 24th of January, all the home nations saw small falls in prevalence, and you can see the numbers there. England, it's 1 in 70 now, Wales 1 in 80. Northern Ireland 1 in 65 and Scotland 1 in 70. So I said now, but actually this data is lagged by a couple of weeks. This is reflecting what happened a couple of weeks ago, and actually the picture has changed since then, and we'll pick up on that in a second. Again, looking down at the regions of England, you can see a sort of time lapse over 4 most recent weeks, grey bars being the furthest away in time, furthest back in time, and orange being the most recent. You can see we've seen falls. Those falls have started to slow down, and in almost all regions we've still seen a fall, except for perhaps the northeast, where it's remained relatively constant. And then looking at age groups, again, same colour charts to show you going from further back in time to more recent in time. You can see now that actually, although some age groups are still falling, particularly the older age groups, which is good news, we've started to see upticks in prevalence in school-age children, and then also in 35 to 49s, possibly. There's some uncertainty around these numbers, which in that age group might correspond to the parents of school children, for example. So already on the ONS infection survey, although we've seen overall falls in prevalence, we've seen rises in some age groups, and actually this is 2 weeks old already. So if you look at a slightly more recent or more up-to-date bit of data, which is the Zoe symptom trackers, this is where people input their symptoms and they do some smart maths to try and figure out how many people are currently infected. Then you can see right at the right hand side of this chart, you can see that the numbers have started to uptick again. Now, a note for the COVID data heads out there, Zoe literally today have changed their methodology so that they're now tracking ONS infection numbers slightly better. So this was a picture that I got last night off Zoe, but this morning they've changed it. So the peaks and troughs are still in the same place, but the absolute numbers are different. So typically we know that Zoe's not been perfect on getting the absolute numbers right, but it is good at picking up the trends early, because there's no sort of delay as there is with the ONS in getting tests back. It's literally just people reporting symptoms in real time. So they can have a very up-to-date forecast, but it's not always the most accurate. But it is usually pretty good at picking up trends. And so you can see this latest uptick first in Zoe data. But you can see how between the two dates, between last night and tonight, they've changed their methodology. So they're now matching the ONS data a bit better. And you can see there has been this uptick recently. And that's actually borne out by hospitalization. So it used to be that hospitalizations would be a slightly lagged indicator compared to cases. But of course, because no one's testing regularly anymore, we don't have that up-to-date testing data. So hospitalizations have actually become a sort of leading indicator of where we're going in terms of COVID. And you can see again at the right-hand side here that we've seen an uptick in the last week or so. We're seeing that in both age groups. Okay, so I've split the prevalence here down into over 65s in red and under 65s in grey, and this is hospital admission rates per 100,000. So I've normalized by the size of those populations. And you can see that actually the hospitalization rate in over 65s is way, way higher than in under 65s. But nevertheless, you're starting to see an uptick in both of these populations, although it's primarily driven by the over 65s. And again, if you look at hospital beds that are occupied, so not admissions now per day, but number of beds occupied per day, you can again start to see this uptick. And interestingly, overall in the data, we're sort of seeing this pattern of what mathematicians would call a damped oscillation. So you're seeing it going up and down, but the amplitude is decreasing each time. So we're seeing lower peaks, but we're also seeing lower troughs as well each time. So if this pattern were to continue, we would see a leveling off at a relatively high level of beds, maybe 7,000 occupied beds consistently across the year for people with COVID, which is a huge strain to put on the NHS compared to pre-COVID times when we obviously didn't have anyone in hospital with COVID. I should say there's no real reason to believe that this damped oscillation pattern should continue in this regular way that it has done, but it's an interesting idea. So that's hospitalizations, and just breaking it down by region. Again, we've got the same color chart here going from most distant past to most recent week here, and orange is the 30th of January. And you can see across all regions, with the possible exception of the Northwest, that we've seen increases in prevalence in hospital admission rates across all these different regions of England. Flu is back, or has been back at least. So we saw a big peak in flu admissions in England, especially compared with previous years. So this dashed blue line here is the 1920 flu season, so just before the pandemic really kicked off, and this dark blue line is this year. And you can see we've had a big spike with prevalence, more than twice what it was, or the hospital admissions rather, more than twice what they were in 1920. But that's come down relatively rapidly actually, and has leveled off in this last week. But to put it into context, we did see flu admissions overtake COVID admissions for a couple of weeks around New Year, but for the whole of the rest of the year, we've seen COVID admissions being significantly higher than flu admissions. And what really matters is not the height of the peak, but it's actually the area under this curve, under each of these curves, because that gives you an idea of the cumulative pressure that's being applied by each of these diseases. And you can see that the area underneath the red curve is much, much, much bigger than the area underneath the blue curve. So flu is still important, and everyone will acknowledge we've had a bad flu season, but every season is a bad COVID season at the moment with these continuous waves that we're seeing. So moving on to deaths, just one slide on this. This data, again, is quite lagged, so this only goes up to early January. You can see that we just about peaked in terms of deaths, and this is deaths recorded by on the death certificate, and COVID doesn't go on the death certificate unless it's contributed to the cause of death. So we can be confident that COVID has contributed to all these deaths. At the moment, we're seeing around 130 deaths a day. It varies between, say, 50 at the lowest ebbs and 130, maybe higher, depending on which wave you're looking at. At the highest ebbs, so maybe somewhere between 70 and 80 deaths a day on average across the whole year. So you can see that that's going to add up to potentially tens of thousands of deaths with COVID over the course of a year. And we have to ask ourselves the question whether we think those levels of deaths are acceptable or not. And then finally, the reason why we might be seeing rises in prevalence, well, there's multiple reasons. One of them is that we've got these two variants growing up and becoming more dominant, but also people are further out from their vaccinations. So I wanted to show this chart. It's a little bit complicated, so I want to take a second to explain it. It shows the percentage of people over time, so times on the x-axis, the percentage of people who are less than 3 months, so that's dark green, 3 to 6 months or more than 6 months away from their last vaccine dose. And red is people who are unvaccinated, so have never had a vaccine dose. So you can see back in September, just before the autumn booster campaign kicked off, we had only about 13% of people who'd had a vaccine in the last 6 months. The vast majority of people, so 86%, had not had a dose within the last 6 months. And then the autumn booster campaign kicked off. So this was restricted to over 50s and people who are clinically vulnerable or caring for clinically vulnerable people. And what you can see is that the number of people who've had a dose in the last 3 or indeed 6 months increases, and it gets up to this peak of around 30% around here. But then obviously as time goes on and people stop getting those boosters, then you can see that this starts to drop down, and we're getting back to this situation where people are increasingly far out from their latest dose. So only 6% of people at the moment have had a booster in the last 3 months, and around 30 in the last 6 months. So that means that overall, we've got around 70% of people who have either not been boosted in the last 6 months or have never had a dose of COVID vaccine at all. And that's a quarter of the English population who are completely unvaccinated. There is, of course, because of these booster campaigns, a significant gradient in this data by age. So if I break it down by age, you can see that of the over 80s, around 84% have received a dose in the last 6 months because of this booster program. Similarly, it's high levels in 60 to 80-year-olds here. And then half of this age group, 40 to 59, were eligible for the autumn booster campaign. So around 30% of them have had a dose in the last 6 months. But then when you look at sort of younger adults and children, then you see that large proportions of them have not had a dose in the last 6 months. And in particular with 5 to 11-year-olds, almost 90% have not received a single dose of the vaccine. Just a sort of comment, last week, the JCVI released a statement about vaccination policy going forward. They are planning to do an autumn booster campaign in 2023 to protect the most vulnerable people, which is good news. But it's worth bearing in mind that the initial booster campaign, which started in December 21, so the third dose for most people, so for 16 to 49-year-olds who are not at clinical risk, that offer is closing on the 12th of February. So you've got less than 2 weeks to get your booster if you've not had a booster. And the autumn booster campaign for over 50s and clinically vulnerable people is also closing at the same time. So if you've not had that and you have the opportunity to go and get it, then it's a good time to go and do that before the 12th. At some point over the course of 2023, the primary course of vaccine looks like that will also be rolled out. So all these people in red will no longer have the opportunity to even get the primary dose of vaccine, which has been available since we started rolling the vaccine out. So it's worth bearing in mind that the offer is being reduced and is closing down. And so if you are eligible and you haven't had one of these doses, maybe I'm preaching to the choir here, but please do think about going to get one. All right, so that's where I'll stop, and I'll summarize to say that prevalence according to the Zoe app and according to hospitalizations, is rising, although the ONS this week is showing falls. Because it's lagged, we know that actually it's much more likely that prevalence is going up again. We're into yet another wave of COVID. Deaths are falling, corresponding to the wave that we've just been through, but are still at the moment at relatively high levels, although again, bearing in mind that those levels are lagged in time. And then more people are further out from their most recent vaccine. That vaccine offer is closing. So please do think about going to get your vaccine if you are eligible. And that's where I'll stop. So thanks.
Kit, thank you very much. Absolutely fascinating data. Can I just say that I don't think you would find 3 better people in the UK to present data each week than Christina Pargle, Kit Yates, and Duncan Robertson. We are incredibly lucky. And it's always absolutely riveting to see these charts because you won't find them anywhere else.
Too kind.
That's one of the important things about Indie Sage. So Kit, thank you so much for that. And your last slide about vaccination is very relevant to our questions. I'm going to go straight into the questions, and our first one is very relevant to that. I'm going to ask Janet Ford. Welcome, Janet. Perhaps you would ask your question.
Oh, thank you. First of all, I'd like to say how grateful I am to the for the information that you give us every week. It's so helpful when everything else has gone really quiet. My question is regarding the vaccine. So we have the current vaccine, which may change slightly due to the variants that, the vaccine may sort of be adjusted. But my query is, will our immune systems be able to take, reoccurring, by having the vaccines over and over and over again, year after year, will our immune system be able to cope with it?
Thank you, Janet. That's a really important question. In fact, we have a weekly meeting the night before these sessions, and I was going to ask last night what the immunologist felt was how often I should have a vaccine. I'm getting on a bit and I've had 4, should I have it every 6 months, every year? So I think this is very germane to what you're saying. Firstly, how frequently should we have boosters? And secondly, can we tolerate them? Who would like to go first on that? Should we go to Danny first and then perhaps Steve? Danny, you're muted.
I'll do a turn. We should have Steve and probably Sheena on this as well.
Oh, sorry,
so just to say, it's a good and important question. And the first thing to say is the sort of general immunology textbook point, which is the key one, which is that our immune systems are busy things which are exposed to thousands of challenges every day, just through living on planet Earth, which is a really dangerous place to live in terms of the pathogens and bugs all around us. So it's not a thing that gets exhausted or distracted by seeing more proteins out of a needle. It's a drop in the ocean compared to what you encounter every day of your life living on this very scary planet. So that's my overarching answer is that that's not a thing to worry about. But if that sounds patronizing, there is a much more detailed discussion to have after that, which is that we never planned for and are in uncharted territory if we're thinking that we might go onto automatic pilot and have mRNA vaccines for the next 6 or 9 or 12-month cycles in perpetuity. That isn't necessarily the best that immunology can do. And in the academic community, there's intense thought and debate and research and trials to see what we might be doing differently or better. But I'll happily turn over to Sheena and Steve.
Yeah, Sheena, maybe you want to add to that.
Yeah, I think I absolutely agree with what Danny just said, that and as an example of an annual vaccine we get every year, that would be the flu vaccine. So it is absolutely normal for us to receive annual boosters of things. However, as Danny says, we should be doing better. And I think it's really important that we ask questions about what are the right correlates of protection. So how do we monitor what protection looks like in people? and so that we're actually planning more strategically our vaccine campaigns. For example, do we need to offer the vaccine to younger people again? And also, we need to think about what we're going to be vaccinating for. So do we need to keep making bivalent vaccines, such as the ones we've just had, or can we ditch the ancestral strain, that original strain? And what is going to be the decision about when we make these? mRNA vaccines can be made very quickly. So currently in America, they're looking at making decisions in June for September vaccination campaign. However, Novavax, which is one of the vaccines that we've been waiting quite excitedly for, is sort of protein subunit type vaccine. It takes around 6 months to be able to be ready. So it can't respond to a June announcement. So there are a lot of decisions. There are other vaccine candidates in the pipeline, but what we don't have is any of these kind of super funding kind of supporting drives that will help those come through rapidly.
Thanks. Can I just ask a quick question whilst I've got the two immunologists here? When I was studying immunology 45 years ago, you taught first time you're exposed to something, you get a little blip of antibodies. And then the next time, because of memory, you get a bigger blip and big. So if you've had 1 or 2 vaccines, and even if it wears off apparently, would you expect that the next time you're exposed to that virus, you're going to get a more rapid response, which might prevent you from going into hospital or dying?
Well, I think that's basically what we're seeing at the moment. Yeah. We're seeing protection from death and hospitalization has really dramatically reduced in people that have been vaccinated, and even more so in the booster campaign, there's been a further reduction. I think one of the issues is whether or not we're getting immunity in the tissues that the virus likes to live in. And that's one of the interest in the next generation of vaccines, is what we call mucosal vaccines that actually develop sort of immunity and memory in those sites.
And of course, in the few people where they get immunological responses that are abnormal and cause problems, perhaps like long COVID, then you don't want that to happen. Steve Griffin.
Yeah, and maybe just touch on a slightly different area of this, which is, I completely agree. I don't think that annual vaccines at the moment are going to be an issue, but certainly not a long-term solution. My concern with what's happening at the moment is about the withdrawal of vaccines for younger people and the sort of longevity of our immunity across the population. Because for many vaccines, we have them preschool before we're going into adulthood. And that sets us up with these sorts of memory responses that Sheena and Danny have been talking about. And I think by not adding COVID to those preschool vaccinations, maybe not as an mRNA vaccine, but as something going forward, we'd run the risk of just relying on infection for our population immunity. We know that isn't a great idea for many reasons, not least it's a much higher risk than vaccines. So I would really like to see that. And in particular, younger children are more at risk than sort of middle-aged children, if you like, of more severe disease, and everyone can still get long COVID. So I really don't agree with a policy that relies upon infection to instill immunity in our population.
No, that's right. And I mean, some of the doctors, and they're quite influential, say, oh, well, it's a very mild illness in childhood. We don't know about we do know about the long-term consequences of COVID.
Yeah.
Affects a very significant number of children. And when people say, as a recent paper did in the past week, it's only 1 in a million deaths of infection. Well, that is 150 children who've died. And in the last 2.5 years, and in the same period before we introduced measles vaccination, I looked at the figures, it was 16 children died. So, that's 10 times the number. So I don't see that as an argument not to vaccinate children. And the other thing is that the USA, Canada, and 29 countries in Europe are all vaccinating children over 5. We're the outlier. It's just us and Sweden. So, I think, anyway, we shall see long term, but I think I agree with you, Steve. Any other comments on that, or we'll move? Oh, yeah, Leonard, please.
Thanks, Anthony. I guess I am a doctor and I treat vulnerable people. So, Janet, I think it's a great question, but I think we try and help you balance the benefits versus a hypothetical risk. And I guess we've got to go back to the main point. Why are we giving people boosters? Why are we going with the vaccination program for the vulnerable? And I think it's really quite simple. It's what Kit said, the 25,000 deaths every year. We want to try and reduce that down. You vaccinate to stop people ending up in hospital. You vaccinate to stop people dying. And I think that's the key point. So I guess the question is, there's a hypothetical risk, which is never proven, but actually there's a real risk of death and hospitalization. And if we can mitigate that, that's great. So my message is very clear. If you're vulnerable, go take your boosters because it's going to protect you. I mean, obviously, there's a caveat. Not everyone responds to vaccines and some people don't get response. But actually, if you do and you can get protection, I think you should get it. So let's put the risks in context there. Vaccines do work. They do prevent hospitalization, prevent deaths. But great question. Thank you for asking it.
Yeah, that's why we get rather cross when certain people in the medical profession, fortunately very few, promote a kind of anti-vaccine line, because vaccinations have saved hundreds of millions of people's lives over. And yes, any drug we ever use or intervention has certain risks, but the benefits hugely outweigh that. Let's go to the next question from Fazane. Welcome, Fazane Beruzi.
Hello.
Welcome.
We're coming from sunny Cape Town, where we also follow Indy Sage.
Oh, brilliant.
And I just wanted to ask, specifically, can somebody please advise on what to look out for a checkup after you've recovered from COVID? And has anybody created a guideline yet? Because the 90 days after infection seems to be quite hazardous. And up to 1 year, we're seeing increased mortality. And even if you have a mild asymptomatic infection, you may have ongoing sequelae. So this is not a question about long COVID, because we have research on that. It's the majority of everyone who's gotten a case. And is anybody looking at that? Have there been any papers yet? Thank you.
Thank you. Are you medical by any chance?
I have some training. I do public health research.
Oh, excellent. No, that's a really interesting question. And yeah, I thought it was going to be about long COVID, but it is a little bit about long COVID. But you're saying population as a whole, should we be screening everyone, or certainly in a research study to look at the ways in which we might predict risk? Anyone like to take that? Oh, that stumped them, hasn't it? Trish Greenhow, professor from Oxford.
And GP, this is an absolutely fascinating question, and thank you for asking it. Because it takes me back to 25 years when my main job was seeing patients in general practice. People get viral illnesses, and one of two things happens. You either don't see them again until they get ill with something else, or they come back saying they're not better. And then as a GP, you start to say, well, what are your symptoms? And let's take it from there. And post-viral syndrome, post-viral lethargy, post-viral cough, all the things that are dragging on of the viral illness, that's quite common in a lot of different viruses. But we would never go knocking on people's doors saying, are you better yet? That's not what the system has been designed to do. But the question you're asking, and I can tell you I don't have an answer to it, but just to kind of pull out the question is, wait a minute, we know that people are at higher risk of, for example, heart disease for quite a long time after COVID. Should we be knocking on their doors, or should there be something for people to check up on with themselves? I know there's some work by the sports medicine people getting athletes back to training after a bout of COVID. I haven't got that at my fingertips, so I'll see if I can dig it out. If I come up with anything, I'll come back on after others have said. But I don't know the answer to that. So one question is, what might that checkup look like? And the other is the health system geared up for it? And I can certainly say the answer to the second question is no, it isn't. But it would be worth exploring. Hope that's helpful.
Danny, you've written a book on long COVID, and do you know any studies that have looked as the population as a whole, just following up? I mean, there have been studies.
Well, I think the way I'd answer the question is first of all to say that if I've understood the question correctly, we know an immense amount from high-level epidemiology, population health, about increased risk of lots of things, don't we? Of heart disease, of hyperlipidemia, of diabetes, of strokes, and that's an enormous data set now that's come out of the kind of countries that are good at collecting that data, either because they've got National Health Service or very large national health insurers. So if you look in the pages of Nature Medicine, they're full of lots of lovely studies of that type. So we've got all the signposts that we need to know it's a thing. So if the question is, how do we translate that into medical care and proper scrutiny and monitoring? That's the $64,000 question, isn't it? What do you do with that data in preventative medicine?
Yeah, just I've spoken about this before. I've had post-COVID symptoms for about 19 months now, since June 2021, with fluctuating fatigue as the main problem. And I've never actually seen a doctor. I have spoken to my GP about it, but I don't think there's much to be done. Fortunately, in the last couple of months, things have got better. I'm not 100%, but 85. But what intrigues me is reading about the employment data and the fact that there are very large numbers of people that seem to have disappeared from the employment market, which is in itself inflationary. Because the more or the fewer vacancies there are, that puts wage inflationary pressure on the economy. And people are talking about this and saying it's all due to the NHS being overloaded and stuff. But I think actually a lot of it might be like me. I mean, I'm only work part-time and I can manage that. But I don't think I could have done a frontline job for the last 18 months or so. So I think this is an economically important question as well as a medical one. Does that help you, Farzaneh? We haven't really answered it, have we?
Martin's got a comment.
Oh, sorry.
Yeah, thanks, Anthony.
Martin, yeah.
Yeah, no, I think that's a really important point. But the other thing to note is that the UK is the only country in the OECD, so 1 out of 38, where the workforce has not recovered or is not close to recovery. Yeah. So I think almost certainly quite a lot of it is COVID and the longer term effects, which have, as you've said, a multiplicity of manifestations. There's long COVID, there's the cardiovascular risk that comes after it. There's a whole lot of other things, but there's also something else going on, I think, in the UK particularly. Now, other countries haven't completely got back to their baseline in some cases, but we are a complete outlier here, and it is having major implications. I mean, obviously, there are other reasons why the UK has a problem with labour force, but there's something really problematic here, and it may well be the NHS is unable to cope.
Yeah. Well, yeah, obviously it's multifactorial. Farzaneh, has that helped you? Are you going to get involved in researching this in South Africa?
So I think it was more of a question for people I know who have been recovering from COVID, because people are coming up with various strange lab results, and they'll report on them. But as Leonard is saying, a health check. Could we start thinking about this so that people aren't going undiagnosed and then they end up with severe effects later?
Yeah, that's an interesting point, and whether it would be cost effective. I mean, I think that would get short shrift in the NHS right now because of the financial pressures, and maybe in the South African health service as well. But nonetheless, I think it's an interesting idea to look at the numbers needed to screen or the numbers needed to treat in order to pick up and prevent something. But we need to know more about what works with long COVID. Yeah, exactly. And some people have argued for, anti-platelet stickiness drugs and various other things. And I'm sure trials will emerge. We'll Trish, yeah, I thought.
Yeah, I'm doing a bit of research with long COVID clinics at the moment. We're running a quality improvement collaborative, and I'm just looking at the data on biomarkers and what tests we should be doing and what tests we should be using to monitor whether people who've been diagnosed with long COVID are improving, or for example, to decide when they might appropriately be discharged from clinic. There are no biomarkers that will tell you whether you've got long COVID. Danny's nodding, he knows more about this than me, but I'll carry on talking because I've got the platform. There certainly aren't any blood tests that you could have that will say you are okay, get back on your bike, go back to work. But what does seem to be highly predictive of how you're going to do is your symptom cluster. If you go onto the peer support websites that the patients run, they encourage one another to know their bodies, to know their limitations. They have the metaphor of the spoons. You wake up, you've got 10 spoons. If you spend 3 of them having a long shower, you haven't got much energy left for the rest of the day, those kind of things. So I think more important than going along and getting a blood test is to reflect, well, am I better? And of course, if you've had a bad dose of COVID, you've been ill for 3 weeks, it's going to take you a while to get back to normal and you have to pace yourself. But actually, the science suggests that your own symptoms and your own pacing is as good a predictor as anything else as to whether you're better. Is that right, Danny?
Yep, agree with every word of that. Yep.
Steve Griffin.
Yeah, I think it's really important. And all these factors that we're talking about are definitely happening. They're definitely measurable. And what's even more worrying, perhaps, is the fact that we are being reinfected, repeatedly infected, and that the risk of these sequelae happening, they're not exponentially increasing necessarily, but they do seem to be additive in the sense that if you didn't have a problem last time, it's possible that you will have a problem the next time you're infected. And so we've talked about why we vaccinate at the moment in the UK. That is primarily to protect against hospitalization. But if we don't get control of prevalence, and Kit showed you all those graphs, the prevalence is incredibly high and it's persistent throughout the whole year. If we don't get a hold of prevalence by other means, and we've always advocated a vaccines plus approach from Indy Sage, then we are going to continue to see this burden on our healthcare systems, and that's as simple as it is, really. And if we don't get on top of it, we're still going to see these in years to come.
Okay, thank you very much. A lot of work to be done there, I think, and good for research, but it's a big problem. Population-based problems which don't present to hospital are often the biggest health problems. So we need to think about that. Right, the next question is from Chris Fraser. Welcome, Chris. Would you like to ask your question? Chris, you're muted.
Hi there, sorry about that. Okay, this is not about vaccines, so I'll stop.
No, don't worry. Can we see you? Can you tell me?
No, because I look a bit like a scarecrow at the moment with lockdown locks, so until I can find a safe hairdresser, the answer is no. I'm too vain, so you'll have
All right, okay, you're forgiven.
Yeah. My question came to my mind late on during last week's briefing, which of course was about looking at excess deaths. And it's just curiosity, really. I'm curious to know whether anyone who's interested in the post-COVID immunity syndrome, dysregulation, whatever it's called, has thought about producing a study to look at how that relates to any deaths associated with the higher peak of flu this winter and other illnesses as well. Is that something that is considered important? Is it something that can be done? I noticed in Kit's graphs that the flu peak was overlaid very neatly over one of the COVID peaks. So I just wanted to know if anybody's looking into that, and is it important, and should COVID be on the death certificates for those people who've died from flu? if there are any. I don't know what the numbers are on that. You know, given all the other major threats that we've got facing us, including bird flu, I hear is coming up, is it important? Does it matter?
Very good question. Thank you. And of course, we're always taught in epidemiology that an association doesn't always mean a cause. So it could be that the COVID, well, we know that flu is very variable each year in terms of the impact it has in terms of infection and hospitalization and death. But your question is whether COVID immunity or lack of it is somehow making us more vulnerable. Who'd like to take that?
And is it relevant to recording, for recording purposes?
Yeah, actually, that's a good point. Do people tend to put flu or COVID on the death certificate? And should one be putting both? That's a tricky one. Anyone? God, everyone's gone quiet. Danny.
Sheena's got her hand up.
Sheena, sorry, I can't. You're muted. I look at the mute button. Yeah, Sheena, go.
I'm sure Danny will add to it as well. So there's been quite a lot of research looking at the sort of long-term consequences of having COVID in terms of our immune response. And there's been a lot of debate and discussion about this. And so far, the evidence seems to suggest that for most people, COVID doesn't leave us with any kind of lasting immune deficiency. However, there do seem to be a subset of people who've had severe COVID that do show some sort of immune dysregulation that lasts sort of 6 months or so afterwards. Now, we don't know what that means in terms of their ability to deal with infection, so it's not impossible. And also, we don't know how that links to other comorbidities that they may already have had, because we also already know that if you've got other conditions, for example, if you are obese, that can affect the way that your immune system functions, or whether you're older, that can affect the way your immune system functions, or if you've got COPD, there's all sorts of things. So we need to keep looking at that, and I think those studies are happening. But your question about sort of the impacts of co-infection are really interesting, and to my knowledge there hasn't been a study assessing co-infection and how the immune system deals with both.
Yeah, thanks. Anyone else? I mean, I always remember, Danny, did you want to say anything? No, I mean, I know this is completely different, but I remember when I worked in Nepal, measles was still quite common then, and we knew that if you got measles, your risk of dying was not just in the 2 weeks after you have measles, but actually for about a year afterwards, that somehow it clobbered your T cells or whatever, and you ended up not being able to resist other things like tuberculosis and stuff in environments like Nepal. So, but Steve, any comments on this?
Yeah, I think, well, measles is an excellent example, actually, Anthony, of a virus that we do know specifically causes an immunosuppressive, it affects our B cells. I think, as Sheena says, I think that there is evidence for some transient changes post-COVID, but we do know that even those transient issues post-viruses are not just COVID at all. So influenza, zoster, are known, for example, to predispose people to more severe group A streptococcal infections, which we may have heard about in the news recently.
You mean for me, chicken pox for the
yeah, so zoster, but flu really does. And so I don't know that, again, association is not causation, but the fact we had a very large flu wave and then also a concomitant large group A strep wave in this country and across other countries in Europe, it does strike me as an interesting coincidence. So, you know, we mustn't just say that it's COVID wrecking people's immune systems. This is something we need to research, and it's something that does happen in other infections as well. And there are very few viruses that are known to cause specific immunodeficiencies in the long term. And I think it's important we remember that.
Interpreting death certificates is always a difficult issue because it depends upon what the doctor decides to write. What's interesting is that in China right now, there's been huge pressure on physicians not to write COVID on death certificates because they don't want to show the full extent of COVID mortality. So there's been some criticism of that actually in the Chinese press about some of that stuff. But I don't know what current GPs would do if they find someone they're not sure who's been tested and they've had would they put it down to flu or pneumonia or COVID? I'm not sure.
Okay, sorry to throw you a curveball there. Thanks very much.
No, thank you, Chris. These are all excellent questions. I'm going to read out some now. Another one actually related to this, if you've been exposed to COVID but not contracted it, e.g. by being very close to an infectious family member, does this affect your own immune response in future? Sheena.
If you've not obviously contracted it, you've either got an asymptomatic infection, in which case you're having an active immune response, or you've got a tremendous immune response and it's so kind of good that it's really destroying the virus as soon as it tries to get in. So I don't think it will affect you kind of long term. It might give you a little bit of a kind of reminder, a little bit of a sort of top up, like it's almost as if you've had a booster, possibly if it's actively infected you.
Yes, my mother, who's 98, is in a home, and she's had flu, got over it, had COVID, got over it, had COVID again recently, and my sister went to see her. My sister ended up getting it and feeling awful for about 3 weeks. My mother just got over it. You know, my
eldest son's avoided getting COVID 3 times now, so he's obviously Superman.
Exactly. Maybe we should, pool their serum and sell it, Anyway, right, next question. This is also linked to this, and then we'll go on to something else. I've seen a lot of papers, and so this is from Marion Dawson. Sorry, the last one was from Andrew Parry. Marion Dawson says, I've seen a lot of papers and social media posts suggesting that repeat COVID infections has damaged people's immunity. This is the reason so many people are ill at the moment. What is Independent Sage's view on this, and especially in light of the widespread myth that the reason so many people are ill is due to immunity being damaged by the lockdowns and safety regulations? I like the way she says that, myth. Do we think it's a myth that the lockdowns and safety regulations damaged immunity? I think I do, but anyway, Steve again.
Sorry, all quite related stuff. So when people are talking about the immunity debt, which I think is what's being alluded to here, they're actually talking about 2 different things. One is that if you don't maintain your cycles of endemic seasonal infections, then you will accumulate more and more people from the younger people that haven't had those infections, and so they may then all get infected at once if that virus comes back. And that's pretty much what we saw with flu, okay? And that's why we should have damn well got our vaccines in order sooner and on a grander scale, in my view, but there we go. So to say that your immunity hasn't been trained by being exposed to lots of different infections, virus X won't make your immunity against virus Y or bacteria B better, okay? It's not like that. That's a misguided twist on what was called the hygiene hypothesis. Actually, what the environmental bugs do is teach our immune systems how not to over-respond to things. So your immune system is exquisitely accurate, and it responds to each different germ that you encounter in a different way, specialized way. So it's not this sort of idea of being fit and healthy and training yourself up like a muscle. It's not true.
Thanks, Steve. I've got a question from Blair Breton. And Blair says, given the lack of vaccinations in China, and given, well, actually, I should say, China is actually quite well covered with vaccinations. The question is which vaccine they've had and whether it's as effective as the mRNA ones. But I think over 90% of people have been vaccinated, but it is lower in the more vulnerable groups. But anyway, given the lack of vaccination, given its vast population, my thinking is all sorts of variants will occur, many not viable. That said, I would like expert views on whether a dangerous variant could occur. Is it a risk in the UK which we're not testing for? Aris. Professor Aris, who is an evolutionary virologist.
So I guess the question is around whether a new variant might arise in China. And I think, yes, the more rounds of replication a virus undergoes, the bigger the chance of a new variant arising. So in a sense, by having another 1 to 2 billion infections occurring globally in China within the scope of a small number of time, it's like reopening the floodgates of evolution and putting it back into the fast lane, and giving the virus the opportunity to generate new variants. Now, whether those variants will necessarily be a challenge globally for the rest of the world is an open question. It depends. We can't really predict that with any great degree of accuracy. There are some reasons to think that, maybe because of the different immunological profile, there may be differences in the trajectory the virus takes. But it might not. It might also spend its time becoming better adapted to replicating in humans over and above and beyond what current variants do. So we're ultimately spinning the wheel of misfortune of variant evolution another couple of billion times, and we'll see what comes out at the other end.
Thanks, Aris. Actually, there's another question from Polly, who says, I'm a London-based GP and have close family members working as hospital doctors in London. There are overcrowded areas in hospitals with patients with proven COVID, influenza, and RSV all together in the same rooms. Some patients have multiple infections. Is this not a catastrophe waiting to happen with emerging new variants? Aris?
It's not great, right? Like if you have a lot of ill people in proximity, passing the virus between themselves, being vulnerable to the virus, and also being exposed to other viruses that are themselves exacting their toll on the patients, that could certainly spell opportunities for variant evolution, for chronic infection, for new things to arise. It's not a good situation to be in.
And that's another reason why we should be wearing good masks in hospital settings. I'm sure Trish would agree with that. Do I just get a nod, Trish?
Sorry, I'm talking away, but I'm muted. Yeah, absolutely. And I suppose the other thing that I was thinking of when we were talking about these patients with lots of different respiratory diseases, all sort of breathing out onto each other, was the how well hospital wards are ventilated, and more generally how well our public buildings are ventilated. And regular viewers will know that I bang on about this. It's going to be much more likely that somebody's going to catch something from the patient in the next bed if two things: if nobody's wearing a mask, but also if the air quality is low. In other words, that where there isn't the ventilation or filtration. Actually, some hospitals have actually pretty good air quality. Other hospitals, the only way of ventilating them is to open the windows, and if the windows aren't open, you need to worry. So there's a lot of things we could do to make our hospitals safer. In the meantime, if I visit anyone in hospital, I wear a mask from when I go into the hospital to when I come out, because there's going to be all sorts of bugs floating in the air.
Whilst I've got you on masks, another question from David. How much do you have to worry about dead spots in rooms? Do the corners hold on to stale air? And air changes per hour figure is valueless if there is huge variance across the room.
I think you'd have to ask a specialist room engineer about that. Dead spots in rooms, it sounds like it might happen. There's certainly dead rooms in buildings. You go into some and that you can tell that the air's been in there for days. But I'm not an expert on that, so I'll have to report back.
I just want to bring in, because a lot of this is all very medical, Steve and Zubaida. with a question that I'm making up now about, based on Kit's data, about the number of people that are not vaccinated and who are not going to get vaccinated in the near future as the cutoffs come. And particularly, we know that poor groups and ethnic minority groups are much more likely to be in those categories. And what can we do about that? Have there been adequate, well, there haven't been adequate, but have there been any campaigns to really target vaccination towards the most vulnerable groups, if you like?
No. I mean, the reality is the only time we saw a campaign that was addressing the issue of lower vaccine take-up among some particular groups in deprived areas, among some Black groups and among some Asian groups, was when the vaccine rollout was at its peak. And it's a terrible message, because in one way, the message the government was sending is, we're only asking you to be vaccinated because we need you to be vaccinated for the whole community, rather than we need it, for you. And there hasn't been anything since. And one of the things that I've been thinking about in this really interesting discussion today, I think, is the notion that risks haven't changed. Risks haven't changed for BME communities, and some of whom that we've known have been more at risk because of where they live, the type of housing, the type of jobs, condition of the housing. So the risks haven't changed at all. And also in deprived areas, the risks haven't changed. And we've got lots more COVID circulating at the moment. We've got vaccine waning at the same time. There's still issues around vaccine hesitancy. And that really concerns me. It concerns me in relation to long COVID, how that's an enhanced risk because there's much repeated exposure. And I think because we're not doing, as Tricia said, anything at all about ventilation. And that links back to Steve's point earlier, Steve's very good point about how young people in particular, younger children, haven't been vaccinated. And we've got classes of 30 plus children, they haven't been vaccinated. There's no debate at all, discussion at all around ventilation in schools, nothing. So the entire rationale right now is let's hope they get COVID and that'll be enough. And it's appalling.
Steve Reischer, you're in Scotland. You have a few vulnerable groups, don't you, down in Glasgow?
Well, I was having a very nice time there, Anthony. I thought we'll get to 2:30 and I'll have been able to just listen and learn a lot, and not have to do any work. And then you suddenly forced me to do some work. So
exactly.
I resent that. I've just written something which tries to argue that when you look at vaccination and the failures on vaccination, because of course there have been some successes, but the failures of vaccination in many ways embody the overall problems with the government's response. Because when it came to low vaccination, on the whole, its response was rooted in a distrust of the public, of blaming the public by saying, look, you don't understand. Either you don't understand the importance of vaccines or you don't care enough about other people to get vaccinated, and responded not only through blame, but the threat of punishment. If you don't get vaccinated, there are going to be negative consequences. Whereas actually, I think that what they should have done, and what we've been arguing for throughout in Independent Sage, is start from the premise of trusting the public and ask what are the barriers to getting vaccinated. And there are two fundamental barriers. The first is a lack of trust, and low vaccination rates are in groups who historically don't have good trust in government for good reasons. Black people have limited trust in government around vaccinations because there have been scandals of medical misuse. And therefore, what you need to do is not to castigate people, to blame them, to threaten them. It's to engage with them. And when you look at local programs of community engagement up and down the country, whether it's been with Black health workers or whoever, it's been incredibly effective. So that's one thing. Trust the public, engage with people, go through their community leaders. And the second one, and again, we've made this point again and again, one of the biggest barriers is practical and it's resource-based. So for instance, if in getting vaccinated, you've got to take time off work and you're on a 0 hours contract, you're not going to do it. If you're going to be a bit poorly for a day or two, as you sometimes are, I mean, of course, overall, vaccines are a good thing, but quite a few people for a day or two, a bit under the weather, and you can't afford to take a day off work, you're not going to do it. So you should bring in vaccination in workplaces to make sure people get paid time off, to make sure that if they're poorly, they get decent sick pay. So there are a series of things you can do, but they need to start from trusting the public and supporting the public, and not from seeing the public as the problem.
Thank you, Steve. Leonard, you're muted.
I want to come in with something positive because I think it's been a difficult conversation so far. I think the difficulty with the head in sand type approach, I think we call it living with COVID, is that bad things are happening. So children are getting it, you've got long COVID, you've got immunovulnerable people keep ending up in hospital, and these are all bad things. But what I would say is that we have the solution in UK science, UK life science, and we've got all the right scientists, and clearly we want to fix it. And actually, I think IndySage is a good point. We'll continue to keep highlighting this because we are putting the focus on where it matters. And I do think that you've got IndySage pushing for us to fix all these problems if we're listened to. And I guess a final plug would be clearly, please sponsor our crowdfunder, because look, we've got solutions in this room and we're ready to deploy them as soon as everyone's ready.
Thanks, Leonard. I had another really difficult question for Martin McKee because I wanted to make him do some work, but we're over time by 2 minutes, so we'll save that for next week. Thank you so much to all our panel. Thank you to all the questioners. Keep sending them in. We didn't cover a few of the ones that you've sent in. We'll carry that over. Remember, we're not meeting next week. We'll next meet on February the 17th, I think. Friday the 17th. Keep an eye out for that. And as Leonard tactfully reminded me, do, if you can, contribute a small amount in the crowdfunder, and we'll try and do that as well. So thank you very much. Keep safe and do have a lovely weekend, and we'll see you in 2 weeks. Bye.
Thank you. Bye. Thanks, Ed.